Thank you very much. Thank you, organizing committee, to give me this opportunity to meet with you. I'm a country, small country, sandwiched between the two diabetes capital of the world, China and India. And I take the brunt of that and see lots of patients as you do. And even though it is like a run-of-the-mill cases, these are quite fresh. And every day I'm seeing young patients with diabetes. And I think in this conference, we are focusing on the young people. So I should have, I got his permission. And this is the photograph that my patient took from his file and shared with me. And I took his permission to share his story. I saw him like 5 months ago, 36 years old male, IT technician, and I tell him, he's doing all this and not any other rest of the exercises. There's no family history of diabetes, and there's smoking. And presenting symptoms was dry mouth, fatigue, tingling sensation on his feet, and few kg weight loss. And the physical examination, he was a little bit anxious, 120/90, but the pulse was 82. The BMI was 20, and the rest of the examination was normal. But the hemoglobin A1C was 14.8, and the urine ketone was negative, and the C-peptide was not very low, not very high also. And the GAD antibody was negative, even though he was a BMI of 20. There was only mild fatty liver. And we started him on basal insulin because the HbA1c was high because of glucose toxicity. And metformin was initiated. And with lifestyle and dietary counseling, 1700 kilocalories diet was recommended. An increase in protein and decrease in carbohydrate intake was recommended. So progression over the 1 week period showed that the blood glucose slowly came down, but it was in the 181 to 300 range. And, repeated food history revealed that we have talked a lot about carb, and in reality, it is not enough to just educate the patient once. And sometimes we health professionals get exacerbated and say, I told him many times, but he didn't follow. So nowadays, my assistant has to sit down with each and every patient and get food history. And then we figure that the only food that we are in our context is eating is only carbs. And this is a young guy who's only using his brain and his hand, and he's not doing his muscle activities, and talk about muscle building and all that. So over the period of time, after repeated diet histories, slowly his blood sugar started improving. Linagliptin was added and basal insulin was tapered off. The last time I saw him was on Monday. His fasting blood sugar was 95 and the postprandial was 116. HbA1c came down to 5.9%, and the weight was stable at 53 kilos. And I again stressed to him the need to improve his muscle mass and physical activity and resistance training so that he can sustain his blood sugar control. So that is the takeaway for this patient. Even though we have not very high BMI, we have GAD antibody negative, not insulinopenic, but not severely insulin resistant young people with diabetes. And we are all seeing that day in and day out. And through this case, I want to highlight, even though it's a learning point is old, diet improvement is extremely important. And patient number 2, I didn't have his photograph, so I did from the AI. And he is very dear to me because he's the son of my classmate who died recently. He is a doctor himself, 34 years old, again, I took his permission to talk about him. He did his MPH, he was doing his MPH, and he was bicycling in Indonesia. And he had 8 kgs of weight loss, and polyuria, polydipsia, extreme fatigue, and he took the flight to Kathmandu, and his dad came with me. Now you take care of my son. He has diabetes. I don't know what to do. He had no nausea and vomiting, only weight loss. And examination showed that he was a little hypotensive, dehydrated, and his BMI was 21.9. Lab parameters showed slightly increased creatinine, and his C-peptide level was very low, and GAD antibody was high. And as usual, he was admitted, IV hydration, treated for DKA, and the patient was switched to basal bolus insulin. and then overlapped with the insulin pump and then, insulin infusion and then stopped. And this was the sliding scale, both nutritional and correctional, along with the basal insulin. And this was given to him. But again, he had repeated visits, visits bringing the sugar readings. And I wish we have easily, yes, we do have insulin pump, but when somebody is CGMS, but when you are just upfront and learning with a new diagnosis, I think I can't just jump to the insulin pump. I have to get some stability with basal bolus therapy and very, very variable blood sugar, but with repeated admissions and his own learning. He did a lot of learning himself, started doing resistance training, and repeated visits, and doing like an investigative journalism, we could get to the some kind of sensible readings, even though we don't have CGMS. His readings got better. And in the interim, my dear friend did not have diabetes-related kidney disease, but he had some another severe kidney disease. He was admitted in the hospital for a month. The son was under stress, and eventually in this process, I had to lose my friend, despite the doctors trying everything. And his son, who's my patient, despite having this challenge of having a funeral in the family, we have horrible food during the 13-day period. He somehow managed to, even after the 1 month after his father's demise, the young man came to me with good sugar readings, and finally the dust had settled, and I had strongly encouraged him to keep his muscle active, and along with the carb consistency, he had mastered the art of carb consistency, and also the importance of the mixed meal for his overall health. And not only him, I had come across a year ago, I don't remember the professor. The professor came with a bunch of 9, 10 young in their 70s to 30s years of age, type 1 diabetes, on CGMS as well as insulin pump. They were from France, and they went to Nepal. Nepal is famous for trekking routes, and they had done a pretty rigorous 10 days trekking route, and they had presented to us. And absolutely the sugar control, the CGMS showed beautiful reading despite walking in the remote part of Nepal. So type 1 also, the dietitian was in the team, the own doctor was on the team, the physical therapist was on the team, and they had been really trained well, and most of the people were showing excellent reading. So even in type 1 person, even though it is like a no-brainer, the carb consistency, the properly nutritious food, dietitian, food history, physical therapy, and it's very challenging to give all the comprehensive care. 20 years ago when I was practicing in the US, the doctor had to do the counseling, and there were counseling teams, but they were not reimbursed. So if you don't reimburse, it's not going to be sustained. So with that analogy, in our country, many of our government settings don't have any physical therapist, any dietitian. One doctor is seeing 150 patients every day. So how can we talk about, comprehensive, compassionate care in our setting? So I want to raise this issue with you, and, together I think we should give value to the young doctors and young nurses who are working in our country, so that they stay in the country and they give proper service to these people, so that down the road they don't get into all these nasty, expensive complications of diabetes. So the learning point here is type 1 can occur in adults too. Again, it is important to have the muscles working. It is important to give the proper nourishment to the muscles. Resistance training is important, and of course you need comprehensive care model, chronic care model to help empower this patient. Now I'm coming to the third patient, who is a female, 34 years old housewife. Her BMI is high. She had type 2 diabetes for 4 years, 7.9 on metformin. Intervention was 1,000 kilocalorie per day traditional Nepalese meal diet, and it had all the balance of the protein, fiber, and everything, fat. And the metformin was stopped because she was part of the direct study. The direct study that Dr. Manilka had talked about, that Michael Lean had proven in the Scotland. We did a one-arm in translational study in Metro Hospital where I worked. And her hemoglobin A1C reduced from 7.9% to 6%. The fasting glucose normalized. There was moderate weight reduction of 3 kilos over the last 3 months. And the patient remained off of metformin. There was sustained glycemic control. The key insight is type 2 remission is achievable through cultural dietary adaptation. Though in the original direct study in the Scotland, they had used total replacement meal. Here we had Nepalese appropriate, and this is a glimpse of that diabetes remission study. You are more than welcome to go and read yourself. And this one is comparable to the kind of food that is recommended in Scotland after that direct study showed that 40% people could achieve remission in type 2 diabetes. The Nepalese diet is below this, portion size, portion size, portion size. And with Professor Michael Lean, we are still working on another translational study in which we are applying this in community level with the active participation of the local community leaders. It is about to start this very week. And this is the recommendation that we are going to do. And I will be really, really excited to share that data. But this one, the hospital-based study result was already published in October in Lancet Southeast Asia. And we had achieved about 30% remission rate. And this is the girl who participated in this, and she was quite happy. We had done interview with her, and initial resistance is there. But eventually she was happy and she was enjoying the feeling good. In the interim, I also developed diabetes, and I am also following the same principle of improving the muscle mass, a healthy, balanced diet. And I also did the CGMS, though unfortunately not everybody can afford the CGMS. And I feel good, but unfortunately there is a bulk of our young patients who are suffering, bulk of the doctors are suffering because they are just, bombarded with patients in the clinic. And you cannot do this acute care model and, bend your hand and write 1 or 2 prescriptions. You need comprehensive, consistent, repeated care. And there's so many success stories. There's so many sad stories. We all know the kidney failure, the eye damage. It is very devastating. But upfront, if we do the legacy, if we do the upfront control, we can do the legacy effect. And I want to be hopeful, and I want to, aim for the best. So persistent care team, compassionate care, consisting of pleasant personality, managing your stress, working on your exercise. Exercise can't be just general exercise. It has to be with the resistance training and a healthy diet, and that delivered through multi-team effort. And we really have to seriously think how we can deliver in our national level. And I would really, really hope that we can sit together and bring something like that, and also work on the primordial prevention and primary prevention. I think I have come to the end of the slide, and I really appreciate your patience, whomever you are here left. And I'm really glad that some of you are still here because this is the last session. And this is a Himal called Nilgiri Himal, or mountain. It is close to Muktinath temple. And I was there like 2 months ago for a short trek, and I welcome you. And this is the painting that I did myself. So I would like to welcome you all to come to Nepal and enjoy our mountains. And I really appreciate your patience.